Hello, Dr. Kwon. It's lovely to meet you. Thank you for doing this interview. I'm Kayla Wakefield, a pre-med student at Howard University and also an intern for DocUpdate.
Yeah. My pleasure. It's an honor to be here today and excited to talk about atopic dermatitis. My name is Dr. Chase Kwon. I'm a board-certified dermatologist. I completed my dermatology residency training at Emory, and I currently practice in private practice in Chicago.
Lovely. So I guess let's get started. The interview is generally about understanding atopic dermatitis, generally its causes, and then looking towards the future.
Okay.
With that, the first question is, for those who may be unfamiliar, how would you describe atopic dermatitis, and what distinguishes it from other skin conditions?
Yeah, it's a good question. So atopic dermatitis, often referred to as eczema, is one of the most common chronic inflammatory skin disorders. It's characterized by intense itching, dry and sensitive skin, and recurrent rashes that really significantly impact a person's quality of life, from disrupting sleep to impacting school, work, and daily activities. What distinguishes atopic dermatitis from many other inflammatory skin conditions is a combination of its clinical presentation and its underlying biology. So it often begins early in life, frequently during infancy or childhood, although it can certainly develop in adults as well. The rash also tends to appear in characteristic locations like the folds of the elbows and behind the knees, and it's typically much itchier than many other inflammatory skin disorders. Biologically, atopic dermatitis is driven by a unique pattern of immune dysregulation along with the defective skin barrier. And over the past decade, our understanding of these pathways has grown tremendously, leading to targeted treatments that address the specific immune signals involved in the disease rather than simply suppressing the inflammation broadly.
That's good information. That was one of the questions I was going to ask you earlier, specifically about precision therapy. I know that we're currently making strides in that for oncology, but it's nice to know that it's happening in dermatological aspects as well.
Yeah.
So I know that you said earlier that immune dysregulation kind of drives the disease, but can you expand on the common description of atopic dermatitis as a multifactorial disease and what current research says about that?
Yeah, absolutely. Atopic dermatitis is certainly considered to be a multifactorial disease where immune dysregulation plays a role, but there's so many other players that are involved. So first, there's the genetic susceptibility. We know that patients with a family history of eczema, asthma, or seasonal allergies are at a greater risk, and researchers have identified genes like filaggrin that play an important role in maintaining the skin barrier. Second, there is that skin barrier dysfunction. The skin doesn't retain the moisture as effectively and becomes more permeable, which allows irritants, allergens, and microbes to penetrate more easily. Third, there's that immune dysregulation, where certain immune pathways become overactive, particularly the type 2 inflammation, which drives many of the hallmark symptoms of eczema, including itch and skin inflammation. Fourth, we now recognize that the skin microbiome plays an important role as well. Patients with atopic dermatitis often have reduced microbial diversity and are more likely to be colonized on their skin with bacteria like Staph aureus, which can further worsen inflammation and barrier dysfunction. And finally, there are environmental factors as well, like climate, soap and detergents, infections, allergens, stress, and even scratching can trigger or exacerbate the disease in someone who's already genetically susceptible. So rather than one factor causing eczema, it's really the interaction among the genetics, the skin barrier, the immune dysfunction, the microbiome, and environmental exposures that leads to the development and persistence of atopic dermatitis.
Okay, that all makes sense. And then the next question is, for primary care physicians evaluating patients exhibiting signs of atopic dermatitis, what should they look for during assessment?
Yeah, so for primary care physicians, the diagnosis of atopic dermatitis is largely clinical. So it starts with a careful history and physical examination. On history, I would always ask about itching because it's one of the defining features of atopic dermatitis. If a patient has a rash that's not itchy, I would pause and consider whether another diagnosis might be more likely. I also ask about a personal or family history of other atopic conditions like asthma or seasonal allergies, since these often occur together. On physical examination, I would look for the characteristic distribution of that red itchy rash, where in infants, the face or the extensor surfaces like the elbows and knees would be more commonly involved, whereas older children and adults often more have eczema in flexural areas like the folds of the elbows and behind the knees. The appearance of the rash also varies depending on the stage of the disease, where acute flares are more often red, weepy, and may contain these fluid-filled blisters called vesicles, and chronic eczema tends to become more thickened and leathery, a process that we call lichenification, with accentuation of the normal skin markings from repeated scratching. It's also important to recognize that atopic dermatitis can look different in patients with skin of color, so that redness may be less apparent and patients may have hyperpigmented or violaceous plaques or more of a bumpy, what we call papular or follicular pattern of eczema. Being familiar with these variations can help to avoid delayed or misdiagnoses. And for initial treatment, regular use of a bland emollient is one of the most important interventions. So having some samples of gentle, minimally allergenic moisturizers available can be helpful. And for active inflammation, an appropriately selected topical corticosteroid is a good starting point, with the potency matched to the patient's age, body site, and disease severity. And if the disease is more extensive, involves sensitive areas like the face, isn't responding to that first-line treatment, or is significantly impacting the quality of life, that's a really good time to partner with the dermatologist who can help guide the treatment with non-steroidal topical agents, phototherapy, or systemic therapies whenever appropriate.
Okay, that makes sense. So even upon initial diagnosis from a primary care physician, you would recommend having those emollients and those corticosteroids as samples.
Absolutely.
And then when should they reach out to a dermatologist? When the condition exacerbates?
I think any time is a great time to partner with your local dermatologist. So if you're not sure about the diagnosis, whether it's atopic dermatitis or a different inflammatory skin disorder, if you're thinking that there may be a component of allergic contact dermatitis where that eczema is caused by an allergen, identifying that through something like patch testing where we're looking for skin allergens can be helpful. Or if you find that the patient just isn't responding to the treatment that the primary care physicians often like to start with, like the topical corticosteroids. Thankfully, now we live in a time when there are non-steroidal agents that can be quite safe, effective, and targeted, so we can meaningfully improve patients' quality of lives.
Okay, that sounds good. And then the last question in understanding atopic dermatitis is, what is the biggest misconception that patients have about the cause of atopic dermatitis or eczema?
Yeah, one of the biggest misconceptions that I face is that eczema is primarily caused by food allergies. Many parents understandably come to the clinic convinced that if they can just identify the right food, their child's eczema will disappear. But for the vast majority of patients, that's simply not how atopic dermatitis works. In fact, we've learned that the relationship is often the opposite. So rather than the food allergies causing eczema, eczema can actually increase the risk of developing food allergies. That's because patients with atopic dermatitis have a disrupted skin barrier, so when food proteins come into contact with inflamed, broken skin, the immune system becomes sensitized to those foods, resulting in food allergies. So in contrast, early oral exposure to foods helps promote immune tolerance. This concept has really changed how we think about the relationship between eczema and food allergy. Another important point is that a positive food allergy test doesn't necessarily mean that a patient has a true food allergy. More than half the patients, half of children with atopic dermatitis may have positive allergy tests because they become sensitized, but many of those results are false positives from a clinical standpoint. So sensitization is not the same thing as a clinical allergy. That's why we generally discourage broad food allergy panel testing or elimination diets without a convincing clinical history. Unnecessary dietary restrictions can actually lead to nutritional deficiencies, increased anxiety for families, and may just overall do more harm than good. So instead, we focus on treating the underlying eczema and reserve allergy testing for situations where the history truly suggests an immediate food allergy.
Okay, so would you say that those misconceptions would stem from miscommunication about the atopic triad?
I think so. So when we think about the atopic triad of asthma, atopic dermatitis or eczema, and allergies, including seasonal or food allergies, it is true that they all tend to run together, but I think the sequence is misinterpreted. And part of that must stem from the frustration of parents who have this lovely newborn that they just gave birth to, and they're struggling with sleeping and just so uncomfortable with their itchy, inflamed skin, and you're reaching for explanations. And it would be nice if we can point to a certain food and say, once we avoid that, the eczema will all clear, but that's simply not how we understand atopic dermatitis and food allergies work.
That makes sense. Next, we're going to move into research unknowns with atopic dermatitis. So what are some of the most outstanding unanswered questions regarding the origin of atopic dermatitis?
Yeah, what's exciting about atopic dermatitis research is that we've answered many important questions over the past decade, but we've also uncovered entirely new ones as well. So one major question is the genetics. So we have genome-wide association studies that have identified numerous susceptibility genes, but together they only explain a fraction of the inherited risks. So what accounts for the rest? Are there additional genetic factors, epigenetic changes, or gene-environment interactions that we're only beginning to understand? We're also learning more about the skin and gut microbiome. We know they're altered in many patients with atopic dermatitis, but we still don't know whether those changes are driving the disease or simply a consequence of it. From a clinical perspective, I'd love to understand why some children, quote unquote, outgrow their eczema, while others continue to have active disease into adulthood, and why one patient may respond beautifully to a particular therapy while others with seemingly identical disease don't respond at all. Ultimately, answering those questions will move us closer to truly personalized care where we can predict the disease course and select the right treatment for the right patient from the very beginning.
Yeah, and that makes sense. And it also makes me wonder about how some of the children that you mentioned, they go their entire lives or they outgrow their eczema, but also it's common for children to go into remission. So would you say that the reemergence of remission is also common, and also one of the questions that you may have about the origins?
I think that's one of the remaining unanswered questions where there's an unpredictable natural history. So I would love to be able to reassure a patient or a parent that they will eventually outgrow their atopic dermatitis at a certain age and it will never come back. The truth is that a lot of atopic dermatitis patients may have severe disease as kiddos and quote unquote outgrow it for the most part, but continue to struggle with dry, sensitive skin into adulthood while others continue to have severe disease.
That makes sense. Also, I know that you mentioned the gut microbiome. That was one of the questions that I was going to ask as well. I know that you said earlier about there's disruption with the skin microbiome, and I was wondering the connection between the skin and the gut, but that was really insightful information.
Yeah.
So next, go ahead. What were you going to say?
Oh, go ahead.
Okay. Next, researchers commonly use the terminology inside out and outside in to describe current theories of atopic dermatitis. Can you explain these theories and provide insight into which one has more scientific backing?
Yeah, I would say historically there were those two competing theories about how atopic dermatitis develops. So to provide a little bit of that background, the so-called outside-in theory proposes that the atopic dermatitis begins with a defective skin barrier. Because the skin barrier isn't functioning properly, the skin loses moisture more easily and allows allergens, irritants, microbes, and environmental triggers to penetrate. And then those exposures then activate the immune system, leading to inflammation. In contrast, that inside-out theory takes the opposite view where it suggests that the primary problem is the immune dysregulation. An overactive immune system produces inflammatory signals that subsequently damage the skin barrier, leading to dryness, itching, and increased permeability. Today, I would say most researchers no longer view those as competing explanations. Instead, the evidence suggests that they're simultaneous and bidirectional. So the skin barrier and the immune system are in constant communication, and dysfunction in one reinforces dysfunction in the other. A weakened skin barrier promotes immune activation, while inflammation further impairs the skin barrier, creating this self-perpetuating cycle. That shift in our understanding has important clinical implications. It helps to explain why modern treatments don't just focus on reducing inflammation. We also emphasize repairing and maintaining the skin barrier with good skin care and regular moisturization, and addressing both aspects of the disease gives patients the best chance of breaking that cycle.
Helpful information. Thank you. And then I guess we could look for clinical implications. We were talking about those topical treatments just recently. So I was wondering, with many treatments on the market for atopic dermatitis, including both topicals and biologics such as Dupixent, what are the current, well, I guess we already went through this, but what does the standard of care look like for these patients that are being treated with these topicals and biologics?
Yeah, so we've made tremendous progress over the past decade in atopic dermatitis treatment, but we still have a ways to go. We have an expanding number of highly effective topical medications, including many that are non-steroidal, biologic agents, and oral targeted therapies for atopic dermatitis. The challenge, though, is that we still can't reliably predict which patient will respond to which treatment. As a result, treatment selection is still guided largely by clinical judgment and patient characteristics. And while we have many excellent options, it often requires adjusting our approach based on how a patient responds. If we had reliable biomarkers that could predict treatment response before even a therapy is started, we could match the right patient to the right medication right from the very beginning. That's really the promise of the personalized medicine that you were alluding to earlier. Instead of this trial and error approach, we'd be able to match the right patient to the right therapy based on their underlying disease drivers right from the outset. So rather than treating eczema as one disease with many therapies, we'd be treating each patient's unique biology with the therapy most likely to work for them. To me, that's really the next frontier in atopic dermatitis research, not just developing more treatments, but knowing exactly which treatment is right for which patient.
Yes, I hope to see that in the future for atopic dermatitis as well. This is a question that I hadn't prepared, but I wanted to ask you, what does current research say about the difference between non-steroidal medications or topicals versus steroidal medications? Because I know that a lot of people experience topical steroid withdrawal. I think its acronym is TSW. So how likely are you to recommend a patient non-steroidal versus steroidal?
It's tricky because I think in an ideal world, I would be prescribing non-steroidal topical agents right from the get-go for all my atopic dermatitis patients. With topical corticosteroids, we know that there are a lot of limitations, like if you overuse a certain topical corticosteroid or use one that's too potent on a sensitive area, which we consider places like the face, the skin folds, like the armpits or the groin area. The topical corticosteroid over time can thin and permanently damage the skin, what we call steroid atrophy. In addition to that, using a topical corticosteroid on certain places like the face may lead to other complications like acne or rosacea, or using it on the eyelids where a lot of adult patients will suffer from atopic dermatitis. That may theoretically increase the risk of things like cataracts and glaucoma. And using too potent of a topical corticosteroid over a large body surface area in an infant or a small human being, we start to worry about complications from systemic absorption as well. But at the same time, we have to recognize from a cost-effective standpoint that topical corticosteroids are much cheaper for the overall healthcare system as well as for patients, which is why insurance companies will often deny the non-steroidal agents that are newer and more expensive, even if they may pose less theoretical and real harm to patients. So we're kind of stuck in this situation between what's ideal and what's cost-effective.
Yeah, that makes a lot of sense. And I think that can be represented throughout healthcare, not even with dermatology or atopic dermatitis.
For sure.
So let's look towards the future with atopic dermatitis. Recently, you attended a conference entirely about AD. What were the developments discussed that you found most exciting?
Yeah, what struck me most was how rapidly the field continues to evolve. So even the idea of having a 3-day conference dedicated to atopic dermatitis was really remarkable. But beyond the development of new therapies, there was a lot of discussion about the biomarkers, the disease heterogeneity, long-term safety data, and our growing understanding of atopic dermatitis subtypes. So one particularly exciting area is the emergence of new therapeutic targets, including those that are more upstream in the inflammatory cascade. And the hope is that by intervening earlier in the disease pathway, we may be able to move beyond simple symptom control and potentially achieve more durable and even remittive effects in some patients. overall, it's becoming clear that eczema isn't a single disease, but rather a spectrum of related conditions that ultimately require different treatment approaches rather than a one-size-fits-all strategy.
Yeah. Yeah. Sorry, I blinked. We're going to edit this part out. But I think that is very interesting. And I think you made a good point about how having a 3-day conference entirely on atopic dermatitis is giving it the representation that it deserves, whereas maybe 10, 15 years ago, maybe that wouldn't have been the case. So I guess kind of as a closing, having completed NIH-funded research in about atopic dermatitis in the past and now currently caring for patients, what aspect of atopic dermatitis research are you hopeful will be answered within the next decade? I know that we discussed biomarker research, but past that, are you thinking about more so treatments that can, like you said, instead of symptom relief, are more targeting the cause instead of, I guess, reacting to the symptoms or the development?
Yeah, for sure. So having had the opportunity to do research in atopic dermatitis during medical school and now caring for those atopic dermatitis patients in clinic as a dermatologist, what I'm most hopeful about is that we continue moving beyond the symptom control towards truly disease-modifying therapies. So over the past decade, we've made remarkable progress in understanding the immune pathways involved in atopic dermatitis and developing highly effective targeted treatments. Many of those treatments can dramatically improve symptoms and quality of life, but like you said, they still primarily function by suppressing inflammation and controlling symptoms rather than fundamentally altering the course of disease. What I'm hopeful we'll see in the next decade are treatments that can more meaningfully change the natural history of atopic dermatitis, interventions that not only control disease activity while patients are on therapy, but potentially induce more durable remittive effects in some patients, even after the treatment is stopped. To me, that represents the next frontier, moving from simply managing atopic dermatitis to fundamentally changing its trajectory.
Yes, that was good. That was very insightful. I also wanted to insert one other question that also sparked my mind, if that's okay.
Yeah.
I was wondering about the differences in demographics in terms of managing this condition and also its onset. So I was wondering which communities are more susceptible to having atopic dermatitis that you've seen in clinic, especially?
That's a good question. I don't know that there's a major difference in terms of the prevalence per se, but one thing that I will note is that because atopic dermatitis can present differently in different skin tones, I feel like the diagnosis can be delayed in certain populations. So classically, with more of your fair-skinned individuals, you are looking for that red weepy rash or the lichenification where from repeated skin scratching, you have accentuation of the normal skin lines. But in patients with darker pigmentation, like patients of Afrocentric descent, for example, we may see more of that papular presentation where it's more bumpy. And someone without experience treating patients with skin of color may miss that and misdiagnose it and go down the wrong treatment pathway. In Asian patients, I've seen cases where the eczema appears more psoriasiform, so it gets misdiagnosed as psoriasis, and that has a different underlying biology and responds to different treatments. So I don't know about the prevalence, but the disease diagnosis can certainly be delayed because of lack of sufficient education in the presentation of atopic dermatitis across different skin tones.
Okay. Well, thank you so much. This was really helpful, and I cannot wait to write my article about this. I think you provided really good insight, and it was lovely to talk to you.
My pleasure. It was lovely talking to you as well.